Hello everyone and welcome to this evening's UEFA medical webinar where we're going to be talking about pain management. As you can see, I'm not Evert Verhagen, I'm a substitution for this webinar. I'm his colleague at UEFA Medical and Anti-Doping, where I work with Evert Verhagen on research and knowledge transfer. So it's a pleasure for me to facilitate this webinar where we have some brilliant speakers with us today. So we have Tommy Lundberg. Tommy, hello, good evening.
Hello.
Tommy is an assistant senior lecturer in clinical physiology at the brilliant Karolinska Institute in Stockholm, Sweden. And we also have Sean Carmody. Hi, Sean.
Hi, everyone.
So Sean currently works in men's football as medical doctor at Crystal Palace and the Football Association of Ireland, but has previously worked in academy and women's football, and is also a keen researcher and is just about to complete his PhD on long-term health in professional football. So as you can hear, we have two very competent speakers for tonight. We'll start with small presentations from Tommy and Sean, and then we'll take an open discussion afterwards. So if you do have any questions throughout the webinar, do feel free to use the chat to communicate with us and ask any questions you might have. So Sean, I'll see you later, and I will hand the floor to Tommy. So Tommy, you will present for us on the physiology of painkillers and everything that's important to know on painkillers for medical staff working in football. So over to you, Tommy.
Thank you very much, Kat, and hello everyone. So my introductory talk here will be about introducing painkillers and sort of the physiology around painkillers, and Sean will then take this further with you guys very soon. So I have no conflict of interest to declare that are relevant for this presentation. So some short background here on analgesic drugs in general. We can establish first, I think, that we're trying to manage pain sometimes in football, but pain actually serve a protective function for the human body as a whole. And we call them painkillers, these analgesic drugs that are quite effective in relieving pain without affecting our consciousness, basically. And anti-inflammatory drugs, NSAIDs and paracetamol, they are both examples of this and the most commonly used painkillers in football. And they are also available, at least in most countries, over the counter, which means that they don't typically require prescription from a physician. In terms of the mechanism of action, they can differ a little bit, but they also have some shared mechanism in terms of their pain killing and inflammatory mediating effect. There are also some other analgesic drugs that are sometimes justified and sometimes used in sports. They may be banned or they may require a therapeutic use exemption. Opioids and corticosteroid injections, for example. But it's clear that anti-inflammatory drugs are by far the most common painkiller used in football, and I think Sean will give you some numbers on this later as well. So there's been some research on exploring what are the actual reasons for why these painkillers are used in football. And some of the obvious reasons are, of course, to treat pain and inflammation that are sometimes caused by training and competition, to treat or alleviate pain associated with soft tissue injuries. But there are also athletes who report that they perceive a competitive edge by using these drugs. And there are also some reports on athletes reporting that they perceive faster recovery as well. Another sort of more maybe indirect reason is that even though there might be non-pharmacological pain management strategies to consider it is a fact that sometimes they are potentially more long-term, or they are certainly not as fast acting all the time, and some of them have actually limited evidence as a whole as well in terms of the function. And some examples then of non-pharmacological pain management strategies would be things such as massage, cryotherapy, light therapy, neuromodulation strategies, psychosocial interventions like cognitive behavioral therapy, for example, or then physical or manual therapy. So how do these drugs work? Basically, if we look specifically at NSAIDs, then anti-inflammatory drugs, they inhibit the COX enzyme and the function of the COX enzyme. And the COX enzyme is needed for full prostaglandin formation. As you can see in the bottom of the slide here, ultimately, prostaglandins are involved in mediating pain and inflammation. So, and if you look to the right on this schematic here, if you block the COX enzyme, you will then limit the prostaglandin formation and therefore limit inflammation and pain. Now, the interesting thing is that NSAIDs may block more than pain because prostaglandins are actually involved in regulating tissue protein turnover, basically adaptations as well. And I will give you a few examples of this. So they may affect tissues and different tissues in various ways. So there's been findings in the upper right one, you see a study from Todd Trappe at Ball State University showing that both actually paracetamol and ibuprofen may limit the muscle protein synthesis response. So basically the building machinery in response to resistance training. And in the lower panel, you can see studies showing inhibited satellite cell response a few days after exercise. Satellite cells are relevant both for recovery, healing, and for muscle hypertrophy, for example. And also the more immediate molecular response in response to mechanical loading. The image to the right is showing the phosphorylation of P70S6 kinase, which is essentially a signal that turns on muscle protein synthesis in response to exercise. Now, we have some ongoing work on this topic as well. We have a manuscript in preparation where we looked globally at all the genes through RNA sequencing. So, and what we see there is that actually daily intake over a longer period of time of ibuprofen significantly and comprehensively actually attenuated the transcriptional response to resistance training, including genes involved in muscle growth regulation, but also extracellular matrix remodeling. And we believe that perhaps this is one of the reasons, one of the mechanisms why we earlier, actually 7 years ago now, my PhD student Mats Lilja published a paper in Acta Physiologica showing that 8 weeks of daily ibuprofen intake attenuates muscle hypertrophy in response to resistance training. So basically the muscle hypertrophic response was almost cut in half compared with what you would expect and compared with what we saw in the control group here when you took the full maximal over-the-counter dose of ibuprofen for 8 weeks consecutively. In terms of performance, then I did mention that some athletes do consider that maybe it's a competitive edge, maybe it accelerates recovery, maybe it affects performance. There's very limited evidence on performance aspects in elite athletes. There is some evidence actually on paracetamol in non-elite athletes, I would say, which makes it sort of interesting to discuss, I think, from an ethical standpoint as well, and potential doping classification standpoint. We could recently see that tramadol, for example, was added to the doping list because there was a study showing 1.5% performance enhancement or so. So this is an ongoing discussion, I would say, in sports. There's no evidence today of faster recovery functionally from muscle soreness. As I indicated before, it may attenuate the cellular response to mechanical loading and exercise, basically. And with chronic, more long-term use, it may increase the safety risk, but also, as I showed, it may attenuate muscle adaptations to training as well. And there are some risks as well. I call these hidden risks in the sense that they may not be evident at all before they actually appear. And that could involve things such as masking pain, which could potentially make you return to play earlier and then maybe cause a higher re-injury recurrence risk. We know that NSAIDs impair the blood platelet function, so you will likely have an increased bleeding risk if you suffer any collision or trauma. In terms of the repair process, prostaglandins and inflammation is part of the typical healing response. So there is a concern that you would sort of blunt the healing aspect as well a little bit. Paracetamol is an interesting substance in the sense that it's the over-the-counter dose is actually relatively close to the toxic dose. So if you exceed the dosage, there's a risk of liver toxicity. And NSAIDs, they can carry increased risk of kidney injury, especially if it's combined with dehydration. The most common side effect would be gastrointestinal tract issues. And again, they affect protein turnover, so it may also affect bone remodeling and increase the stress fracture risk a little bit. And then there are some more uncommon but more serious cardiovascular events that has been reported as well, and they seem to increase, particularly with more selective COX-2 inhibitors, which are not the most common ones taken in sports. So I think overall, in any sort of athletic situation and in football, we need, and I think Sean will extend on this, but we need to do some kind of cost-benefit analysis, because obviously they are effective in alleviating pain, but on the other hand, medicine should be, and painkillers should be considered only one component of pain management. And as I showed, they can come with unwanted physiological effects and hidden side effects. It should be medically justified to use them. Stakeholders need to be educated about potential side effects and implications of drug use. And if you prescribe analgesic drugs, you should, of course, be aware of the prevailing rules in terms of doping, banned substances, and the rules regarding therapeutic use exemptions. Thank you.
Thank you very much, Tommy. Super interesting, and we will do a very quick substitution with Tommy and in with Sean to give us, as Tommy rightly just said, probably more applied perspective of the topic of pain management. So Sean, over to you and your presentation.
Thank you very much, Kat, and thank you, UEFA, for inviting me to discuss pain management in football this evening. And thank you, Tommy, for your excellent presentation overviewing the physiology underpinning analgesics in football. As Kat mentioned earlier, I'm a doctor working in professional football with the men's national team with the Republic of Ireland, a team doctor at Crystal Palace Football Club, and completing my PhD at the University of Amsterdam, looking at the long-term health of professional footballers. I have no conflicts of interest to declare. So as Kat mentioned, I'm going to come at this from a very applied perspective, and I'm going to reflect on the clinical approaches to the management of pain in professional footballers. And then I'll also touch on some key clinical governance procedures that can be put in place to ensure that we are prescribing appropriately and safely with respect to pain management in football. I used this slide in my presentation at the UEFA conference in Lugano, basically highlighting the high use of analgesic medication, but in particular NSAIDs in professional football. Dr. Philippe Scholl from Switzerland has done outstanding work in this area, highlighting how frequently these medications are used, particularly in major tournaments. And as I said, NSAIDs are the main culprit here, but we also see analgesics are reasonably highly used as well. And it's not just an issue in men's World Cups. We also see it in the women's game. We see it in futsal. We see it in disability football and in domestic football as well. And again, as Tommy mentioned, NSAIDs are the most common medication that are prescribed, or in some cases potentially overprescribed, but analgesics follow not too far behind. So I'm going to take the clinical approach today and overview how a clinician might approach pain management in a football context. And I think good medicine is good medicine anywhere, whether that's in the hospital, whether that's in primary care, or whether that's at a football club or within a football organisation. And we start with identifying the source of pain and establishing a diagnosis, and using all of the information available to you from the subjective history, from the player's previous history, from your clinical assessment and examination, using any imaging modalities you may consider, such as ultrasound or MRI to establish the diagnosis, or in some circumstances as well, blood tests or other investigations that you might use. The real strength of working in football is that we get to know our patients and our players very well, and that means that we can tailor our management according to them as an individual, and take a really individualized approach to player care based on their previous injury history, based on any pain experiences they've had in the past. And another strength of football is that we have all these great people working around us from other domains and other disciplines who are able to offer pain modifying treatments, such as physiotherapists, osteopaths, psychologists, sometimes nutritionists, and other professionals as well, who are working within the interdisciplinary team. And it's important to take their perspectives as well, as they may be able to offer solutions to managing pain. And once you've considered all of that, you might think about medical management in the form of medications, if that's indicated, but that might also go alongside the other interventions as well, as part of a multimodal approach to pain management. In terms of the sources of pain in football, well, the most common types of pain we will encounter are musculoskeletal, so players who are coming back from surgery. It might be bone issues in the case of bone stress injuries or fractures, tendons, ligaments, and muscles. And your approach to each of those will differ significantly in terms of how you might manage the pain. We do sometimes see neuropathic pain in the form of lumbar radiculopathies or other causes of nerve type pain. Dental pain is a common thing we encounter, and we would work closely with dentists to think about how to manage the underlying pain there. In the women's game, certainly dysmenorrhea or menstrual cramps or period pain is something we also commonly see. And also we would also think about inflammatory causes of pain or rheumatological causes of pain when we are considering how best to manage things. So in terms of the usual approach in medicine, we would consult the World Health Organization's pain ladder. There are limitations with applying this to sport, purely because it doesn't consider the underlying pathology, and how we might manage a tendon versus how we might manage a muscle injury when it comes to pain management is very different. And if we take a uniform approach to pain management, then we risk creating problems for players and mismanaging them. When we are thinking about pain relief, we typically talk about paracetamol, and Tommy's overviewed the mechanism of action and potential risks with that. We also think about codeine medication. But as I said earlier, NSAIDs are the most common medication. And as Tommy described, there are different, these do work in slightly different ways depending on the NSAIDs you prescribe. And that's important to consider when you're thinking about the side effect profile or what exactly you're treating. And we also have combined formulations as well. And one of the advantages of these, and particularly for medications like cocodamol, which include codeine, is that you can adjust the dose accordingly based on the what you're treating. We also think about the type or the route that we would prescribe, and we want to typically prescribe with the least invasive route. So starting with topical in the form of potentially patches or gels, depending on what you're treating, and then most commonly is oral medication. When it comes to inhaled medication, so that's typically only in the acute setting where there may be a significant lower limb injury, which is you're managing pitch side, and that player may require Penthrox or Entonox. But bear in mind that there are considerations about how these medications are stored, as they are controlled medication. Intramuscular as well, again, probably you would favor oral medication over that, but in some circumstances there may be an indication for intramuscular medication. I mentioned intra-articular as well, so the common types of formulations that would be injected intra-articular in football context might be hyaluronic acid preparations, PRP, but also corticosteroids. Now, we probably aren't prescribing those as often in professional football because of potential risks to the underlying cartilage, but it's important to mention that as well. So I mentioned codeine-based medication or opiates are sometimes prescribed in football, and I thought it'd be useful to look at what are the risks of prescribing these types of medications. We know that these medications can bring put players at risk of addiction, so we would only ever prescribe them for a short period of time if they're indicated, and they are also accompanied by significant gastrointestinal side effects such as constipation or nausea, and they can also affect the mood. But I thought it was interesting just to highlight some of the sport-specific considerations with these medications. Tramadol, which is a very commonly prescribed medication in the community, was added to the WADA prohibited list in 2024. And it's important to educate the players around this because they don't just get medications from their team doctor, they also may obtain medications from other sources such as family. So they must be aware of the potential risks of taking these medications. And these, the opiates such as tramadol or morphine may require a therapeutic use exemption, and especially when there are alternatives available, the likelihood of successfully getting this is debatable. I thought it was important to mention that these medications can also interfere with the pupillary responses, which is important from a neurological assessment. So we know how important it is to manage head injuries appropriately in professional football and to perform an appropriate assessment, and being on these medications could interfere with that assessment. It can cause drowsiness. Definitely that might have an effect on performance for players, and also pragmatic effects such as driving to and from the training ground as well, things like that to consider. The first side effect mentioned for opiate-based medication in the British National Formulary is arrhythmias. It's not the first thing we think of, but certainly in our active population, this is something worth bearing in mind. Tommy covered these in great detail in terms of the side effects of NSAID use, so I won't spend too much time here. Common side effects are gastrointestinal, potentially risks to kidneys, and cardiovascular side effects. For the most part, the evidence seems to suggest that these are more common in the elderly population with comorbidities, but I do think it's important to highlight that the risks are amplified in heat and with concurrent illness. So this is particularly relevant for players who might be under your care. Both my colleagues and I, including Kat, we developed a safety checklist for prescribing of NSAIDs. Essentially, it's a safety checklist where physicians are able to, rather than just giving out these medication without giving it too much deliberate thought, this just provides some pragmatic steps that you can put in place to make sure that we're prescribing these safely. So starting with safety checks, thinking about allergy status, thinking about whether this player has asthma, for example, and occasionally NSAIDs can exacerbate asthmatic presentations, thinking about the clinical indication and judgment. So that's really important. What's the underlying pathology we're trying to treat? Are we doing it to mask symptoms? Is there a risk that by masking symptoms, we are going to extend this injury? So it's worth bearing that in mind very carefully and using your appropriate clinical judgment. Open dialogue, again, every interaction, every encounter with the players under our care, we're able to give them some education around the risks and benefits of these medications and alternative things they can try, and encouraging them to engage with other practitioners who may be part of the MDT, who may be able to offer pain modifying interventions which are non-medical. Of course, it's important to record this, and that's particularly helpful if over a period of time we feel players are overusing these medications. And then again, I touched on the strength of working in football is that we see these players day to day, we build good and strong relationships with them, we're able to evaluate the response to the treatment, and we're able to adjust that accordingly, increase the dose, decrease the dose, stop the medication, switch medication, and that's a real strength of working in football. Tommy touched on this, so I won't talk about it too long, but players typically use NSAIDs to treat pain, fever, and inflammation, the most common indication generally for these medications, but they may also use them for prophylactic pain reduction. They may also use them as part of their recovery, and they may also think that it might maximize their playing career and immediate health, and they might be thinking about their next contract or the next big game. So the context is often important for why these players are using it, and sometimes a more senior player may just use this as part of their pre-match ritual. It's always important for us as medics to be mindful that they may be getting their medications from elsewhere as well. We've seen that there's high variability in terms of how these medications are prescribed. So there's not much consistency amongst practitioners, and that is, both from a geographical perspective, but also within countries as well. Practitioners just have different approaches, and that probably suggests we don't have a great grasp on the evidence for these medications or the appropriate indication for their use. We know that the context drives prescribing behaviours, such as major tournaments and even progression within major tournaments. And of course, at different times, practitioners may come under external pressures, and it's important to be mindful of that and to work closely with colleagues to make sure we're always prescribing in an appropriate manner. I'll touch on this. It's something I always need to look at over and over again. We know that the days are gone when we can just give an injection to a player on the day of a game, and we need to really think about corticosteroids if they are indicated under specific indications, having a really detailed thought about whether a therapeutic use exemption may be appropriate or may be indicated, and of course you may need appropriate imaging to support that, specialist letters, reviews to support that. So it's always worth double checking and referring to these guidelines to make sure that you are accurate with the washout period and any other considerations for this type of intervention. This slide is very important. I think good governance underpins good medical practice. So in your club, in your organisation, in your team, think about bringing in a medications policy. Have some thought around the specific details or the specific indications for different medications, and when you would use them and when you might not use them. Take a shared decision-making approach. Consult other colleagues if appropriate. Certainly consult with the player and allow them to understand things, so that it's a shared approach to management. It's important we audit our prescribing behaviours as well, and encourage peer review. So working with your colleagues to ensure that you are working in the right way. When there's any issues, for example, any player reports significant side effects or has any adverse event as a result of taking medication or prescribing errors, for example, it's important to document this, and conducting significant event analyses is a good way to review this and bringing in the rest of your colleagues doing so. Education is so important, but we have seen education isn't the only thing that changes behaviour, and even with FIFA's efforts around World Cups, it hasn't massively reduced prescribing behaviours. But thinking about when you do it, so with my work with the Republic of Ireland, as part of our mandatory annual anti-doping that we do as part of our UEFA adherence to UEFA guidelines, we also add in some education from an NSAIDs perspective and other medications as well, so players have an opportunity to ask questions and understand when it's appropriate to take these medications and when we should think about other alternatives. And then the UEFA screening, so the annual UEFA screening encourages annual urine tests and annual blood tests, and they're helpful to give us baseline on player health and to ensure that they're not having any issues such as renal issues secondary to overuse of medications such as NSAIDs. So my final take-home messages are: pain management in football should be based on sound clinical reasoning. So working hard to establish the diagnosis and thinking, are medications appropriate in this instance? It should be specific to the individual, and I think that's an area that we can continue to grow and evolve in the coming years as we improve our understanding of how to give individualized care, and definitely consider the broader MDT in how you support this player. It does carry risks taking medications, and such as side effects. It can exacerbate injury, and there are also anti-doping risks as well. And finally, prescribing frameworks such as the keeping score approach and strong clinical governance principles can mitigate against the risk of inappropriate medication use in footballers. Thank you very much.
Thank you very much, Sean. Well, thank you to both you and to Tommy for giving us insights on this important topic from two different perspectives. We'll now switch to more of a conversation and discussion, and as always, we'll open up for any questions that might come from any listeners out there as well. So feel free to put them into the chat. But Sean, I'll throw the ball right back at you because you highlighted some really interesting numbers on usage of NSAIDs in football. From memory, it was nearly one painkiller per player per game in men's football, at least. So from your review of the literature and your lived experiences, do you see different trends in terms of how pain medication is used between playing levels, sex, age groups, and different cultures?
Yeah, definitely, Kat. And as I said, there's been some great work done by Philippe Scholl and colleagues looking at the numbers of medication use in elite tournaments. Speaking broadly around my experiences, certainly with the older player and older profile of player, we can see maybe they're more inclined to use it versus the youth footballer where it's not as commonly prescribed. In the women's game, from my experience there, typical indications might be around during menstruation along with dysmenorrhea, but certainly it probably wasn't as commonly prescribed in the women's game for MSK complaints, but that may certainly be changing in recent years. So yeah, the key differences are the older players tend to be more likely to take it, and also the context drives as well. So the importance of a game or the importance of a tournament seems to be a key driver here.
That's really interesting. When I was playing football at a much lower level, I had a couple of teammates who, for every single game they would play, would take an ibuprofen before going onto the pitch without necessarily having any particular injury or any pain that they were sort of managing. Is that something you see in elite football as well?
Well, I think that's a really important point you made about, football isn't just the professional game or the elite game. Football's for all, and we need to get the education out to the broader community as well, that these medications are not benign and they do carry risks. And also certainly some of the research Tommy's highlighted there about these risks just going beyond the ones we commonly think of, but also risks around their effect on physical adaptation to training. So that's a really, really important. But yeah, I think it is something that you do see some players are just used to taking these medications for each game, and I don't think it's appropriate to try and change that straight away. I think certainly bit by bit educating the player, allowing them to understand the potential risks that are there, and over time changing behaviour. I think that's the approach to take with that.
Thank you, Sean. That's really relevant, and I think diving a bit deeper into this, when you have as a medical doctor in the team having to differentiate between what is appropriate pain management and when is it sort of medically sort of doing potentially risky pain masking, what's your guideline between balancing between these two variables when you're giving advice both to your medical team and to players?
Yeah, I think the point I mentioned earlier on in the presentation about just establishing the diagnosis, identifying what's the underlying pathology, what's the reason the player is taking it. If they have a significant muscle injury and we give medication with the view to reduce pain, well, that's probably a fairly reckless way to prescribe. But if it's a case of they have a reactive tendon, for example, and we feel it's appropriate to reduce the pain so that they can function and also do their rehab exercises, then there may be a clear indication for that. So for me, it's really, understanding what is the underlying pathology there, and that establishing that comes from an excellent clinical assessment and appropriate workup if needed.
Thanks, Sean. I think, Mike, what Sean also alluded to there is that the communication with the player and making sure that they understand the rationale behind the decision making from the medical team is super important. And Tommy, you highlighted several sort of aspects of risks associated with use of, for example, NSAIDs. So I think you described really well like what the risks are for repeated use of NSAIDs that might affect the body. But how would you translate that into a message to a player where the professional language might not be or might be different?
Yeah, I mean, I think dose and duration of use is really, they are key factors here, because you normally take these for short-term benefits in terms of alleviating pain and potentially reducing inflammation, and the negative aspects, both in terms of risks, sort of health risks, but also the potential risks of this use affecting actually muscle adaptations, for example, to your training regimen. Those risks increase with chronic use and high dose usage. So really that you ought to think about, kind of like Sean said, what's the actual reason for taking these drugs, and there should be a clear justification, I think. And if you take them for a very long period of time, typically there are other pain management strategies that should take over if you have long-term problems, really. So I think it's sort of challenging this aspect that you, like you said, you take it almost as your security blanket. You take it every game or every training just in case, kind of thing. And I think you have to then work both with the structure in a way within the sport and within the team on how do players get these drugs, what control measures do we have, do we know who are using them and how they are using them, but then also work with the culture, because it's also a culture question within the team. So kind of both with the structure and the culture to get the usage where it's needed, but take away the sort of unnecessary use, I think.
No, that's really important messages to get across to players. Similarly, we also mentioned corticosteroid injections and highlighting the potential impacts of long-term usage for things like joint integrity. Again, how do you best communicate, the risks of such usage to medical staff or players?
Yeah, I mean, I think one thing that I have sort of realized, just going a bit back and forth between the Nordic countries here in Scandinavia, is that there seems to be slightly differing views actually on injections between countries as well. I perceive that some countries are much more liberal on the use compared with other countries, which I think is interesting itself, and kind of I see it as a possibility for the football community via UEFA or national federations talking to each other on guidance or expert consensus on the topic to better help individual federations and clubs. Reasons sometimes for for using this, but there are many considerations. Sean mentioned some with the therapeutic use exemption and the medical indication, potentially guided by imaging, but also the fact then that they do have a sort of quite dramatic effect, or can have, on the tissue itself and on the both the composition of the tissue, but also the turnover on the tissue. So you really need to plan it well then in terms of the loading in the next days, etc. So strength in the tissue goes down for a while. So you really need to consider carefully when and how to use these injections, because there may be risks with it.
Thank you. Thank you. It's really interesting. We have one question from someone listening in, so I think we can get that on. Yeah, there we go. So Massimo was asking whether, I think that's maybe more for you, Sean, whether you always use gastroprotection if you only use anti-inflammatory.
So it comes down, thanks for that question, Massimo. So it comes down to two things really. One, the individual, again, if they have any history of any gastrointestinal effect after taking an NSAID, you may also prescribe PPI as gastroprotection for that. But also, Tommy mentioned the different mechanisms of action as well. So COX-1 versus COX-2 inhibitors. So depending on what you're prescribing, you may also, if you're using a medication such as diclofenac, you may be more inclined to prescribe gastroprotection when you know that the risk of gastrointestinal side effects are higher, whereas prescribing a medication such as celecoxib or teracoxib, the risk is lower. So you may not. I think also it's important to consider the age of the athlete. So we do these side effects as well. So you may be more lower threshold to prescribe them. So I make a clinical judgment depending on the individual and also depending on the medication that's being prescribed.
Perfect. So if I get that right, Sean, so just to summarize, so you consider the age of the athlete, you consider the drug that is being prescribed, and you consider the gastric health of the.
No, that's summarizes it well.
Perfect. Thanks. Well, I think we can then move on to, I think we've set the stage now, I think we've established the fact that this is something that's very commonly used, and that it's not just that painkillers are not just simply something we use without having to consider the risks associated with it. So appropriate management is absolutely. Tommy just mentioned, that there are cultural differences. We shift that focus to the players, Sean, and think about the sort of the psychosocial, the cultural factors within the athlete's sort of attitude to the usage of painkillers. How do you see that sort of impacting the willingness to use or potentially overuse these drugs?
Yeah, it's a really important point Tommy's made. I think the players' health beliefs is really important. And now with team squads often be made up of players from lots of different countries, players may come from places where they may really value these medications or feel it's really important to take these medications for specific circumstances. So again, the education piece is really important there. Within an international environment, you have players coming from different clubs with different prescribing behaviours as well, and that can also influence how you might approach things. So I think it's really important to understand your player, understand their health beliefs, and that doesn't just apply to NSAIDs and the use of analgesics, but it also applies to how they might engage with other interventions that might be on offer from those working within the MDT.
It's really important factors, and I think you alluded to the fact that you've just been offering education on this topic within the national team that you're working with. So if someone wants to implement similar style of education, is there any things in terms of like how to approach the players, in terms of the education that you think is essential for people out there to consider?
Yeah, and I think with any educational intervention, we should try and come at it from a few different angles. The reality for footballers is that they are time poor, so they don't have lots of time. They have a lot of demands on them. They obviously, you need to prioritize their meetings with the coaches, the team meetings, all those kind of things, and they can't be having big long workshops, particularly in short international camps, for example. So what I try to do is to layer that education on something else. So the anti-doping education is mandatory, so that seems a nice place to fit in. But I've seen some great examples of, for example, nutrition education being done during a recovery session. So you're layering that on, so you're not taking, the players are feeling like this is a burden or you're taking our time here, but actually they're more engaged, and it's maybe at another opportune time. I think that's a good time to do it. And then in terms of the type of content you will include, it's everything we've spoken about today, both myself and Tommy, in terms of when you might use these medications, what risks are associated with them, and particularly emphasizing the alternatives available.
And, I always feel like depending on who you approach in terms of education, like the selling points always vary. So from your experiences, what is it that sort of catches their attention in terms of the buy-in of adhering to the guidelines in terms of appropriate uses of the drugs that we've discussed?
I'd be lying if I said that any of it really entertained them, or any of them really valued any particular area. But I think it's just getting across the key messages about when what the right indications for these medications are, what the potential risks are, but definitely thinking back to the more recent one of the questions that came up was around tramadol and why that was put on the banned list, on the prohibited list, because that would be a medication that obviously it's well known and people have heard of tramadol. So that was an interesting observation, an interesting question that came to me. And again, it just reaffirms that you assume that players will know certain things, but that was maybe new information to some people, even though we're nearly 2 years into this medication being added onto the prohibited list.
And it's such an important point that it's important to update players on which, first of all, for medical staff to stay updated on which drugs are on the prohibited list and which requires a TUE, and keeping the players updated as well, so that they are aware. So yeah, thanks for highlighting that, Sean. I have another question from someone listening in. So Ola is asking, how does the demand of the sport affect your management of pain, like at the end of the tournament or games of big importance? So Sean, would you alter the way that you manage pain depending on the importance of the games?
Yeah, I think that we know from the evidence shows that as teams progress in major tournaments, prescribing goes up. So prescribing of NSAIDs and analgesics goes up, and that's probably twofold for two reasons. One, because of the load related, issues, but also it might be the threshold to prescribe might change, and people may be inclined to take more risks. I think with all of that, it comes back to what I said earlier on around shared decision making. As long as the player understands the risks, as long as they're able to verbalize and communicate the risks, as long as that's discussed and you're not being reckless or putting this player at really significant harm, then you might see that depending on the context, there may be a change in how you prescribe, and also that might change between teams as well. So your threshold to prescribe in a youth team versus a men's national team or a women's national team or a women's first team or men's first team, the threshold to prescribe might be slightly different, and that's where taking that individualized approach and using appropriate clinical judgment, I think, becomes really important.
Thank you, Ola, for your question. Building on from Sean's answer, Tommy, saying that it might vary what your decision making is depending on the age group and the sector you're working with. We know that drugs interact with the body differently depending on on your age or your sex potentially. So is there anything that we know in terms of the various drugs that we've been discussing today in terms of how they interact differently depending on the age or the sex of the player that we have to be aware of as medical staff prescribing it?
Yeah, so I think the most obvious factor in a way is the body size and how that relates to the dosage, because obviously if you prescribe the same dose, one to a 100-kilogram player and one to a 50-kilogram player, that's a pretty big difference. So body size is probably the biggest thing. There are some limited evidence, I would say inconsistent evidence about pharmacodynamic differences between sexes. There are also some reports about differences depending on the menstrual phase, etc. I suppose one consideration for female players is that they may use painkillers for menstruation problems, and then they may have other pain-related issues at the same time, related more to the actual play of football, which then would be sort of a double consideration then, and it's important then to discuss and have an open climate, of course, so that people in the support staff are actually aware of who's using drugs and why, because so that you ensure that that weighs in on the decision to prescribe. And then in terms of children and adolescent athletes, I'd say that, you know, we are typically more conservative and should be. They have growth and maturation going on. They have a situation basically where most of their tissues are supposed to be on a net positive balance when they grow, and you could also make the argument that, you know, this risk benefit analysis differs a little bit when it comes to young players, and the research on risks, etc., is also typically lower or less extensive on children and youths. But on the other hand, these are, I think, sports consideration. But if you look at the typical prescription dosage, they don't really differ between sexes, and they don't take age too much into account. It's more kind of related to body size in the end, I would say.
Thanks, Tommy. Sean, anything you want to add, having worked with various sort of football populations in terms of your prescription culture?
Yeah, well, I guess it's just being, like Tommy made a good point there, that you may, particularly in female footballers, they may be self-medicating for menstrual pain, and then you might be giving them another NSAID on top. So just having that understanding that, you know, that they're not overdosing on as such on these anti-inflammatory medications. I think that's important to highlight. But yeah, other than that, I'd echo everything Tommy said.
I think that's a brilliant point, and you know, it might just be like for male or female players a headache that they've self-managed as well. So always making sure that you are fully aware of the consumption on that given day or in a relevant time frame is essential as medical staff. So really good points. Thank you both. And Tommy, I think we've talked a lot about uses of medication, but you mentioned as well some non-pharmacological pain management strategies like massage, cryotherapy, manuotherapy, and so on. From your perspective, how effective are they compared to the uses of drugs?
Yeah, so I think one sort of relevant factor is, of course, the time perspective. Of course, in the very long run, it's extremely important to identify why the athlete is in pain, if it's more acute pain from an injury, or if it's more chronic pain, because obviously in the long run it is sort of tackling the issue of pain, if it relates to fitness or flexibility or anything that you can work with in the long term in terms of strength and conditioning and physical therapy work, or even cognitive behavior therapy if it's more chronic pain related. Then obviously those factors would be you would you're not relying on medicines, and B, it would be more effective than to use other ways of pain management, basically. But on the other hand, the sort of short-term benefits of painkillers can be really strong. So it's really about finding that balance, because they're really intended for short-term use. I think that's important to emphasize. So there are few interventions where you would get this sort of immediate pain relief from non-pharmacological pain management strategies, and that's probably one of the reasons why we see such a high uses. Together with the fact that some of these interventions that we use, they probably have relatively limited evidence, to be honest. So I think that those are the considerations there.
Thanks, Tommy. Is there anything that you want to add from the applied perspective in terms of these alternatives, Sean?
Yeah, I think the key thing to highlight is actually occasionally medication can be useful to actually allow more, like for example during the rehab process, if it's to reduce an effusion, so you can do activate the quad more, or if it's or to do your rehab exercises more in the case of a tendinopathy, for example, so you can follow a loading program to actually dampen down the effect in the short term, so then you can get go after the things that we know can be really beneficial in the rehab, and that's another indication that you might consider them.
Perfect. Thank you both. So coming towards the end, I think we've highlighted this several times, but I think talking about any medication, Sean, from your perspective in terms of anti-doping, what are the key messages to get across to medical staff when it comes to uses of any sort of pain management?
Yeah, I think you can just never take anything for granted in football when it comes to anti-doping, and never assume any medication is permitted, even, down to paracetamol, and checking what you're giving is actually what you think you're giving. So never becoming complacent from that perspective, I think, is really important with the medical staff. Never becoming complacent in terms of your procedures for the dispensing of medications, to ensure that that's all being done in an appropriate way, and also how that medication is ordered, stored. All of those things are very important from a clinical governance perspective, and are important to be highlighted in any medications policy that an organisation might have. From an anti-doping perspective, the three things I encourage players to know about and not to forget about, and this also applies to staff, is just the concept of strict liability, that ultimately they're responsible for what they take, and knowing where to check medications. In the UK, it's Global Dro. In Ireland, it's MedChecker, and also supplements as well, and knowing that supplements are appropriately batch tested, and there's some helpful resources around that. So they're kind of the three things messages I get across to players when I'm teaching them from an anti-doping perspective.
Brilliant. And given that they're well educated and don't fall into the trap of accidental doping, from both of you, a final sort of message on how we best keep our athletes healthy with the usage of pain management for a long-term career. Tommy, any sort of thoughts or messages you want to give to the listeners?
I think a lot of clever things have been said here, especially from you, Sean, who has the practical experience. But in my view, I would kind of, as a physiologist, think, take them use them for what they are meant to be used for, and then together with that discuss how to best manage this in the long term, both working with the structure around the team to avoid and reduce risks as much as possible, including the very important doping risks, but also the cultural aspects. And then obviously there are potential concerns as well for some. We talked a lot about painkillers here and over-the-counter drugs, but there are also these opioids, for example, where you actually may have severe issues with the addiction risk, for example, in terms of long-term usage, which may affect you even after your career, which is then obviously a very big consideration as well.
Thanks, Tommy. Sean, anything to add?
Yeah, and look, with it being the subject of my PhD, the long-term health of professional footballers is something that I'm very passionate about. What drives pain medication use? It's typically injuries and physical issues. So for me, the message is let's work together to try and prevent injuries and work in a collaborative way with your coaching team, your sports science team, your medical team to do your absolute best to prevent player injuries, because that will hopefully reduce the need for these types of medications.
Brilliant. Thank you very much, Sean Carmody and Tommy Lundberg, for brilliant insights, both from the applied and the research side of things. Before we finish off, I just want to let you guys know about our next medical webinar, which is coming on the screen here. So on the November 24th, we will be talking about the cartilage injuries of the ankle with Gino Kirchhoff and Peter Duke. So that's all from us. So thank you very much for listening in, and thank you to our brilliant experts for joining us today.